of Gastroenterology at CMC Vellore. He has publications and research on various topics, including visceral leishmaniasis, diabetic ketoacidosis, and the impact of COVID-19 pandemic on endoscopic services. Today's topic and his areas of interest are therapeutic endoscopic ultrasound, third space endoscopy, and narrowband imaging in gastrointestinal procedures.
Good afternoon. This afternoon, I'll be talking on recent advances in GI endoscopy. I'll be briefly covering narrowband imaging, third space endoscopy, and therapeutic endoscopic ultrasonography. So coming to narrowband imaging or NBI. So what is the need for NBI is as in general, the GI malignancies are increasing. So this is the Globocan 2022 data, which shows that the age standardized rate for colorectal cancers in India is on an upward trend. And colorectal cancers actually are ranked second in terms of mortality. Gastric cancers account for fifth of the mortalities. So we also know that if we pick up cancer early, we'll be able to treat it earlier. So what is NBI? So this is a white light endoscopy. So in a white light imaging, we use the full spectrum of light. But if we use an NBI filter, we can have these two wavelengths, that is the 415 and 540 nanometer. So this creates a contrast between the superficial and deeper mucosa, and we are able to appreciate things or lesions better using NBI techniques. So hemoglobin actually has an absorption peak at 415 nanometers, and so it absorbs blue light, as I had shown earlier, and the capillaries in the superficial mucosa are highlighted. Green light, on the other hand, penetrates deeper into the mucosa, and because of this, there is a contrast between the superficial and the deeper structures. So in essence, in NBI, we are looking at the vascular pattern and we are looking at the mucosal pattern. So as we all know, there is a lot of angiogenesis in pre-malignant or malignant lesions. So there will be a change in the vascular pattern, which is what we are trying to pick up. In the mucosal pattern also, as the surface epithelium changes, there will be changes, and which is another thing which we try to pick up using NBI. So coming to gastric cancer, as we all know, early gastric cancer has a 5-year survival rate of more than 90%, whereas advanced gastric cancer, the survival rate comes to 20%. And most of the patients, by the time they develop symptoms, are already advanced. So just talking about normal and NBI findings in the stomach. So as we all know, the stomach has two separate organs physiologically. So one is the body and the fundus, and then there is the antrum. So this is an NBI image of the antrum. So these are the small reticulated capillaries that we can see. And this is the area surrounding it is the surface or the mucosal pattern. This is the body and fundus NBI appearance. So here we see a hexagonal shape of capillaries, and these things are the collecting venules that are seen. So NBI, especially using magnification, has been proven to have better detection rates for gastric cancer when compared to only the white light imaging. So especially when NBI and white light is used, there is a sensitivity of around 95% and a specificity of around 97%. So just a brief case, a 50-year-old man with a family history of gastric cancer, a past history of H. pylori infection, comes for an endoscopy. And this lesion is found. If you actually look carefully, this area is a little depressed. It's a palish color. And if we use NBI, we can see that there is something different in this area. So this is the normal area. Here there is some sort of a demarcation, and there are some kind of abnormal vessels here. So this is where there are multiple classifications for gastric cancer. This is one of the classifications, that is the VES classification, that is the vessel and surface classification. So it just means there should be a demarcation line and an irregular surface pattern or an irregular vessel pattern, and it has a very high predictive value for diagnosing early gastric cancers. So, based on these findings, there have been a lot of guidelines, especially in Japan. So, if there is a suspicious lesion and these findings are there, so there's a demarcation line or there are irregular findings, you can actually confidently diagnose cancer. But however, I would say that white light examination is also a must. There is no direct NBI for gastric cancers. And secondly, biopsy is always required because for a cancer, you cannot rely just on endoscopic or findings alone. Coming to colorectal cancers, so there was a lady with who was a 50-year-old lady with a family history of colon cancer. And on endoscopy, we found this sessile polyp around 1.5 centimeters in size. So considering the various options that are there, what will be the best for her? So this is where the again NBI comes into play. So this is one of the classifications by the Japanese NBI expert team. So again, it is just based on the vessel patterns and the surface patterns. There are different types. And what this can tell you is the submucosal invasion. And so if it is a deeper lesion, surgery may be required. So for this lesion, when we used NBI, it was a JNET type 2B, and which implies that there is submucosal invasion, and hence an endoscopic resection is needed. So does NBI help? Is it better than white light endoscopy? So there was a meta-analysis of 11 RCTs. So in patients with adequate bowel preparation or the best bowel preparation possible, there was a marginal improvement. Or when everything was combined, there was a marginal improvement when NBI was used. So NBI can also be used to differentiate non-neoplastic and neoplastic polyps. So in a meta-analysis of 28 studies, using NBI, the detection of neoplastic lesions was 91% and a specificity of 82% was noted. So what are the implications of this? You can have a real-time diagnosis. So while doing the endoscopy, you can actually say this is neoplastic, this is not neoplastic. And also with polyps less than 5 mm, they can be removed without histopathology. So as we know, biopsy adds to the cost of the procedure. So this cost can be averted. So this is mainly about NBI. So once we diagnose or we find something in using NBI, like I mentioned with the polyp, what are the ways to remove it? So as we all know, the entire GIT has 4 layers. So the mucosa, the submucosa, muscularis propria. So this third space endoscopy is basically playing around with the submucosal space. So endoscopy into the submucosal space is called third space endoscopy. And now there are multiple procedures utilizing this third space endoscopy. And I'll be just focusing on 2 of them. So achalasia cardia is actually one of common conditions that we see in our department. So for achalasia cardia, there are 2 treatments available. One is a Heller's myotomy, which is a surgical procedure. The second is a peroral endoscopic myotomy. So I'm just playing a short clip of what a poem is. So we are creating a submucosal tunnel, and this is the tunnel creation. So the obstruction is here, and this is the myotomy. So we are cutting the muscle fibers so that this tightness is relieved at the lower esophageal junction. And then we close this flap with clips. And then there is a patient generally has good resolution of symptoms. These are the endoscopic images that we see. This is the submucosal space, the glistening white. So there was an RCT published in 2019 comparing POEM and laparoscopic Heller's myotomy. So the clinical success, that is patient improvement of symptoms at 2 months, 2 years, was similar between both the groups, and the adverse events were also similar between both the groups. The only thing regarding POEM is there is a higher rate of reflux esophagitis as compared to the Heller's myotomy. And but this is easily managed by proton pump inhibitors. So coming to endoscopic submucosal dissection. So like I had shown earlier with the polyp. So it is generally polyps which are involving the submucosal space, which can be dissected out using this technique. Otherwise, these patients will require surgery. So it is used for non-pedunculated lesions or sessile lesions, which are greater than 1 centimeter, and especially when there is a submucosal invasion or suspected submucosal invasion, or when they are depressed or pseudo-depressed. So this is a video of a endoscopic submucosal dissection we did for a colorectal polyp. So this is injection and lifting the submucosal space, cutting into the submucosal layer, and dissecting out the lesion. So this is, we use specific knives for that, which electrocautery knives. This is the muscle layer which is being exposed. And in the end, we are left with this muscle layer. So at times we have to close the defect. At times we can leave it open based on the scenario and where we are doing the procedure. So ESD is, there was a meta-analysis which showed that it has an en-bloc resection rate of 91% and R0 rate of 82%, and the adverse events are less, and the need for surgery was only 1%. So that is about third space endoscopy. Now I'll be coming to therapeutic endoscopic ultrasound. So like my colleague Santosh had talked about, so EUS is basically using ultrasound inside the stomach. So this is what was a few years back or 10 years back. So find a lesion, put a needle inside and diagnose. But now there has been a paradigm shift to therapeutic EUS. So this is actually a stent being placed inside the jejunum. So we can access newer areas, different lumens. We can drain obstructed systems using therapeutic EUS. So I'll just briefly go through two cases. So this is a 36-year-old man who was diagnosed with acute pancreatitis, ethanol related. And he comes with abdominal fullness, so basically gastric outlet symptoms. And an MRCP shows this. So this is a walled-off pancreatic necrosis, and this blackish area inside is the necrotic material which is seen. So earlier, this used to be treated by surgery, so a surgical cystogastroscopy. But nowadays, we can do a EUS-guided cystogastroscopy. So this is the cyst cavity, and we assess the cyst, we puncture, and we place a guide wire into the cyst, and we burn a tract into the cyst, and then we can deploy a metal stent into the cyst so that whatever is inside can be drained out. So this is the metal stent which is being deployed. It's a covered metal stent. And we can see the pus draining from the cavity inside. So patients generally do very well with these procedures. So there was a randomized control trial published in Lancet in 2018. So which compared endoscopic versus surgical options for patients with walled-off necrosis. So the outcomes were mortality at 6 months or a composite of major complications. So the endpoints in both the arms, that is the endoscopic arm and the surgical arm, were similar, but there was a higher rate of pancreatic fistulas in the surgical arm. Also, we have to realize that as the pancreas is a retroperitoneal structure, surgeries are more complicated. Patients have a much longer duration of stay. So endoscopic options are better. So this is another patient with who presented with obstructive jaundice and he also had a gastric outlet symptoms. So on this an endoscope, when we did a upper GI endoscopy, we could not cross the D2, and he developed cholangitis while in the ward. So we had to do a PTBD for him. So the question here is, how do we relieve this man's gastric obstruction? So generally the options are a surgical gastrojejunostomy, or we can place a stent across this region. So that is a duodenal stenting. Or what is newer is EUS guided gastroenterostomy. So through the stomach, as the jejunum is here, we can place a stent across this. This is called a lumen opposing metal stent. And the food from the stomach directly goes into the jejunum. So this is the obstruction. We can hardly see into the duodenum. So this is the jejunal loop as visualized from the stomach. We distend it with contrast and methylene blue. And then using a device called a hot axios, which has cautery and a stent. This stent is deployed into the jejunum and the stent is being deployed. So that blue color was the methylene blue which was coming out, and this is the jejunum on the other side. So this is a EUS guided gastroenterostomy. So what is the evidence for this? So another thing is most of these patients have a higher ECOG, so may not tolerate surgical procedures. So there's a meta-analysis of 7 studies which compared gastroenterostomy versus duodenal stenting. So gastroenterostomy had higher clinical success, lesser adverse effects, and lesser intervention rates. EUSGE versus surgical gastroenterostomy, the technical success was lesser in gastroenterostomy. However, the length of stay was lesser. As I said, these patients with higher ECOG may be difficult to treat surgically. There was also a randomized control trial comparing EUS gastroenterostomy versus duodenal stenting. So the reintervention rates and the stent patency was better in the EUS gastroenterostomy group. So take home message from these things. So one is NBI is an adjunct to white light endoscopy in diagnosing early gastric cancers. However, in these conditions, histopathological diagnosis is always needed. Colorectal diminutive polyps that is less than 5 mm may be resected without histopathology using NBI. And ESD can be used to resect selected submucosal lesions. And EUS gastroenterostomy is an emerging treatment for malignant gastric outlet obstruction. Thank you.
Thank you, Dr. John, for that talk. I would now like to invite Dr. Vijay Alexander, our next speaker. He's an assistant professor in the Department of Hepatology at CMC Vellore. He has published multiple articles on plasma exchange and its applications and other complications. His areas of interest are acute liver failure, plasma exchange,